Today's lecture, Research to Practice Overview of CAR T Cells and Toxicities with Natalie Grover, MD, and Faith Brianne Buchanan, PAC. Natalie Grover, MD, is an assistant professor in the Division of Hematology Oncology. Her primary clinical interest is in the management of lymphoma. Her research interests include novel treatment strategies in lymphoma, particularly immunotherapy. She is currently involved in clinical trials of chimeric antigen receptor T cell therapy for patients with lymphoma. Dr. Grover, welcome. So glad to have you here today.
Happy to be here. Thank you.
And what's one thing that we should know about you outside of your professional bio there?
I guess one thing that some people don't know about me is that I'm actually fluent in Russian. My parents are originally from Russia, so even though I was born in the U.S., I actually learned Russian first before I learned English.
Great. Thank you so much for letting us know about that. And we are so glad to have you here. During clinic, you made time for us, so we're especially grateful. I also want to introduce Faith Brianne Buchanan, and she is a physician assistant in Chapel Hill, North Carolina, working with the bone marrow transplant and cellular therapy program. She graduated from the George Washington University Physician Assistant Program in 2005, having more than 15 years of experience working with cancer patients. She has spent 10 years of that time specifically in bone marrow transplant, previously at Duke University, and now here at UNC. Brianne, welcome. Thank you so much for being here.
Thanks a lot, Tim.
And same question to you. What's one thing we should know outside of your professional pursuits?
Well, so it's not as fantastic as speaking Russian, but I started out as a zoology major undergraduate, and trying to decide what I wanted to do before PA school, I actually spent a summer as a zookeeper in South Carolina, doing sea lion training, working with the lemurs, and cleaning up a lot of after a lot of warthogs.
All right. Well, that's great. Thank you so much. Well, I mentioned poll everywhere, and here's the question. Our first question is usually kind of a softball. CAR T immunotherapy is the re-engineering of cells from a patient's immune system to create modified cells that are designed to recognize and direct the attack against the patient's cancer. So true or false, and we'll let you go ahead and take a shot at that in just a moment. And while you're looking at that, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Natalie Grover, MD, and Faith Brianne Buchanan, PAC, have no financial relationships with commercial interests as defined by the ACCME. Phew. Okay. And let's take a look at that poll, and we're already getting lots of responses. Thank you all so much for jumping right in there with the polling. As I mentioned, totally anonymous, so take your best shot at this. Dr. Grover, Brianne, how are they doing?
Doing great.
Yep, looks pretty good.
All right, well, let's go ahead and move on. Overview of CAR T cells and toxicities. I'll let you two take it away from here.
Great, thanks. I'll get us started. So thanks for the wonderful introduction, Tim. And we can go on to the first slide. So today we're going to do a little bit of overview of CAR T cell therapy. Our focus today is really going to be on the current products that are recently approved, as well as the ones that we have at our disposal currently. So we'll look at first the initial trial results for CAR T products and the initial approvals, and then look at the new products that have been both approved for new indications of existing products and new products entirely. We'll talk a bit about toxicity and current management of the toxicities associated with CAR T therapy. And then Dr. Grover will also give an overview of some of the exciting things that we have going on with the UNC clinical trials and the new routes that we're taking with that. So we can go to the next slide. So to start out with just an overview of what CAR T cell therapy is. Next slide. So first of all, what we will do is we collect T cells from a person from their blood, and the T cell is a type of white blood cell, also known as a T lymphocyte. They are designed to kill foreign substances. What we do is train them to identify the tumor cell. We do that by, next, not really slide, button, by using viral DNA to insert a CAR T, which is a chimeric antigen receptor, so it's a receptor to identify this antigen, into a T cell to train them to identify the tumor cells. Next button. Once the CAR T cell is infused back into the person, it can then identify the tumor cells. And how T cells work in general, and CAR T cells do as well, is that to be able to kill the tumor cell, they multiply and proliferate. Next button. So once they have created more cells just like themselves, the cells in that process are releasing cytokines, which help the T cells kill the tumor cell, but also cause some of our side effects that we'll talk about later. Next slide. So how do we make them? This is a fairly detailed slide. We'll go over it pretty quickly. So to make a CAR T cell, we can either use a pharmaceutical company. There's also a manufacturing facility for research products here at UNC. We collect blood from the patient, and then the T cells are selected out of that blood, and we activate them using specific co-stimulatory molecules. And what we do is we take that virus and we put in the manufactured antigen receptor to allow these T cells to be supercharged to be able to identify and kill the particular cancer cells that we want. Those cells then are grown to make more of them, and then there is a period of time where they will go through both freezing of the cells, but also testing to ensure that they are functional and also not contaminated with anything. Once all that process is done, then they're going to be ready to be given back to the patient. Next slide. So when we're looking at what type of antigen we want these T cells to target, it is extremely important that we find an antigen that is located on the malignant cancer cell and not on healthy tissue. We certainly don't want these T cells being infused in and attacking healthy tissue such as lung tissue or cardiac tissue in a patient. We just want them to have as much specific expression as possible in those cancer cells. When CD19 was identified as an antigen on many cancer cells, but initially first the acute lymphocytic leukemia cells, it was actually a really fantastic antigen and has led to a lot of the success of the initial CAR T cells. It is also located on B cells, which are healthy B cells as well. So the unfortunate cost of also being able to target these cells is that we also will deplete the patient's healthy B cells, but that is a necessary evil in being able to get the functionality of these cells, and we can mitigate that and the patient will be okay. So it actually turned out to be a really great marker, and where a lot of the initial success in the larger products for CAR T cells was done. Next slide.
So I'll be talking about the clinical activity, kind of segueing in from what Brianne just mentioned and talking about the clinical activity of CAR T cells in leukemia and lymphoma and what led to some of the initial ones to be FDA approved. Next slide. So I'm going to start off with a case example. An 18-year-old female who's initially diagnosed with leukemia, B-cell ALL, B-cell acute lymphoblastic leukemia in 2010 at age 11. She's initially treated with an aggressive regimen for pediatric patients, chemotherapy, and achieves a remission. But unfortunately, she relapses and then undergoes a stem cell transplant. She then goes on and many years later presents with routine blood work that shows that she's relapsed again after transplant. Next slide. And so prior to CAR T cells, there were really limited treatment options available for patients with ALL, B-cell ALL, who relapsed after transplant or were ineligible for transplant. As Brianne had said, CD19 is an ideal target for CAR T cells for B-cell cancers such as B-cell leukemia. And so the trial for CAR T cells that led to the approval of Kymriah or Tisa-cel, which is a CD19 directed CAR T cells, was the Eliana trial. And that looked at pediatric and young adult patients with leukemia and showed really high response rates in these patients in the 80% range, as well as some durable remission seen. So this kind of really revolutionized the treatment for these patients with relapsed refractory B-cell leukemias. Next slide. So these promising results led to the FDA approval of the first CAR T-cell product, tisagenlecleucel. All of these are quite some word soup, or Kymriah for pediatric and young adult patients under 25 for relapsed refractory leukemia. There's still a lot of unanswered questions, including the role of transplant for these patients, and there's also interest in looking at escape mechanisms with because many patients with leukemia still relapse and sometimes have relapse that is CD19 negative, so they develop a resistant clone to the CAR T cells. And there's also a lot of interest about access to care because this treatment is so expensive. It's $475,000 for this treatment. Next slide. Another case, moving on to lymphoma, there's a 56-year-old female who has a really aggressive lymphoma, diffuse large B-cell lymphoma with a poor prognosis. She's initially treated quite aggressively with chemotherapy, but unfortunately progresses at the end of therapy. She's then treated with a salvage regimen, another salvage regimen, more chemotherapy, and again, doesn't respond. So the question is, what do you recommend for therapy? And CAR T cells have really changed the conversation about this. We know that patients like this have a very poor prognosis. There was a retrospective analysis done looking at outcomes of patients with large B-cell lymphoma who were refractory, and they found that these patients had a response rate around 25% to their next therapy and usually only lived about 6 months after that. So that's kind of the benchmark used for future CAR T cell studies. Next slide. And so now there are 3 CD19-directed CAR T cells products approved for lymphoma. The first one was approved in October of 2017, and that was Axi-cel or Yescarta. And then a little over 6 months later, in May of 2018, the FDA also expanded Tisa-cel, which was already approved for leukemia, to lymphoma as well. And next slide. And then in 2021, we now have a third product approved for large B-cell lymphoma, and that's Breyanzi or Liso-cel. And all of these have very similar indications. And I'll talk a little bit about them and the differences and kind of the data behind them in a second. So next slide. So now in 2021, we have a lot of we have so many of these 3 products now approved for large B-cell lymphoma. So the question is, how do we choose them and what kind of went behind that? So there's 3 products, as I said, the Axi-cel or Kite, Tisa-cel or Kymriah, and Liso-cel or Breyanzi. And so I'll briefly discuss the differences between the products, but I won't go into the super nitty-gritty. Next slide. So the first question is that this co-stimulatory domain. So the co-stimulatory domains are that second signal in second generation CAR T cells, which are important to improve their signaling capacity and lead to improved expansion and persistence. In terms of the construct, Axi-cel has a CD28 co-stimulatory domain, while the other 2 products have a 4-1BB co-stimulatory domain. And we know that CD28 co-stimulatory domains lead to a more rapid expansion with boosted effector function, while the 4-1BB leads to more gradual expansion of the T cells, with shifting to kind of a more central memory-like phenotype, and that leads to longer persistence. It doesn't seem that this longer persistence matters as much in lymphoma as opposed to leukemia, but in lymphoma, this plays out more in terms of toxicity, which I'll touch on in just a little bit. Next slide. And one more. And the other thing is about the manufacturing component, is that Liso-cel has a fixed 1-to-1 ratio of CD4 and CD8 cells, and it's unclear whether that adds an advantage, but that's the other difference in terms of manufacturing for these products. Next slide. And you can do one more. And then looking at response rates, they're over 50% for these products. And as I had mentioned before, prior to this, kind of the next line of therapy, the response rate was closer to 25% for any kind of treatment for patients that are this high risk. And so basically complete response rates ranging about 40 to 50%, and it appears that these responses seem to be quite durable for patients who achieve a complete remission. One caveat, I know you look and see differences in these response rates between the products. I think it's really hard to compare because all the trials were designed slightly differently, and there were different inclusion criteria in the different trials. And a big criticism in general for CAR T-cell trials is that we kind of think the trials are only looking at patients who actually get treated. And so as Brianne had mentioned, there's a whole process of CAR T-cells being collected and manufactured, and that may take weeks. So there may be some patients who are too sick eventually to get treated or can't make it to treatment. So that's not conveyed in these results. That's something to think about when you're looking at CAR T-cells and response rates and the data behind that. Next slide. And basically showing that for patients who respond, these responses seem to be durable, as I said before, where the duration of response for patients who are in a complete remission at 12 months was not reached. Most of these patients that are in complete response are responding over a year. Next slide. In terms of the toxicities, we think maybe partially related to the costimulatory domain difference I talked about before. So axicell is the one that has a CD28, while the T-cell and lysocell have the 41BB. Axicell seems to have earlier toxicity and have higher rates of cytokine release syndrome. You can't see that as much when you're looking at this slide here. Because they use different grading system when they compare them, but it does look like axicell does have more cytokine release syndrome, kind of from experience. And there's also higher rates of neurotoxicity. And this later onset of toxicity for the T-cell and lysocell with the 41BB costimulatory domain, has a little bit less rapid expansion. It seems like they have later onset of toxicity too, and that kind of moved more from a practical standpoint that we're able to give these as an outpatient because patients are developing toxicity a few days out from treatments. They won't get readmitted right away potentially. So that also, that's kind of the most, from a practical standpoint, these patients seem to get later toxicities. Next slide. And then neurotoxicity, similarly, axicell seems to have higher rates of neurotoxicity and also earlier neurotoxicity than the other two products. So and it's really hard to choose. It's hard to choose between these three products, and really we just think about hard to make conclusions about efficacy, and people are looking into that. But if someone were older and more frail, I may consider one of the 41BB costimulatory domain products since they seem to have be more easily tolerated. Next slide. So new from 2020 is Brexucil or Tecartus hit the market, and this is also a CD19 CAR T cells for relapsed refractory mantle cell lymphoma, which is another type of lymphoma. It's very similar to axicell. It also has a CD28 costimulatory domain. The one main difference is the manufacturing process removes circulating CD19 expressing malignant cells. And the thought is that they are more likely to be present in mantle cell lymphoma. And this reduces the thought is that this would reduce activation and exhaustion of CAR T cells prior to infusions if you don't have malignant cells in the blood that you're collecting, circling around. The clinical trial enrolled patients who progressed on a BTK inhibitor such as ibrutinib or acalabrutinib and had high response, and the patients had really high response rates, as you see here, 93% response rates and a really high complete response rate. And the follow-up was really short, but it seems like these are maybe durable remissions. The toxicity profile is very similar to axicell. This product is also being evaluated for leukemia patients, B-cell ALL. The thought is, they also have a lot of circulating CD19 expressing malignant cells as well. And that data is going to be presented in ASCO this year for leukemia, and the company has also Kite has also submitted to the FDA, so this product may soon be approved for leukemia as well, potentially in the late summer, early fall. So we may have another product for leukemia. And now I'll talk about other new indications in 2021 approvals in lymphoma, and then Brianne will talk about myeloma. So in addition to lysocell or Breyanzi for large B-cell lymphoma, we're excited to see axicell or Yescarta, the CD19 CAR T label, expanded to allow for treatment of patients with follicular lymphoma. And so that's an indolent lymphoma, but there's a subset of patients with follicular lymphoma who have really bad disease that have a poor prognosis. So we were excited in March to see that now we can treat those patients with CAR T cells. And just briefly go over that data in the next slide. the data for follicular lymphoma was quite strong. The response rates for these patients were quite high, as you can see, also over 90% response rate, and the majority of those were complete responses. We don't have very long-term data, but it seems that these also patients seem to maintain a response at least at 1-year follow-up. So this is quite promising, seems to be quite promising for patients with follicular lymphoma as well. Next slide. Moving on to safety, I'm just highlighting the differences. The majority of patients still had cytokine release syndrome, and Brianne's going to talk a little bit more about these toxicities as well shortly, and slightly more than half had neurotoxicity. But what was different from aggressive lymphoma data is that very few patients had really high-grade toxicity, and some of this may be due that this is now 2020, these studies were done in 2020, 2019, 2020, when people had more experience of managing CAR T-cell toxicity. So some of it may just be that because people were managing them better, there were less people who had more severe toxicity, but some of it may also be related to the disease as well. And the other interesting factor is that the timing of onset of toxicities also seem to be later, 4 days. So that means that potentially we can treat some of these patients as outpatients because they're less likely to be admitted within the first few days, similarly to some of the other products. And so the Axicell or Yescarta is now approved for follicular lymphoma. Tisacel or Kymriah also has similar data for follicular lymphoma, and they're also looking for an FDA indication or expanded indication soon. So we'll see. I'm looking forward to that as well.
All right, so I'm going to go over what we have for multiple myeloma. This is the first year that we actually have a FDA-approved product, so it is the new kid on the block. My guess would be if it was a new kid, it would be Donnie maybe, but that's up to everyone else. Next slide. So what is a good myeloma target? Are we talking about HER2 new? Sorry, Tim, are you doing this?
Oh, you go ahead. You're doing great.
BRCA or BRCA, BCMA, or CD22.
All right, and whether you're using the app or the website or texting, any one of those will work. We, again, always appreciate everyone jumping in and taking their best shot at this. And just take about 5 more seconds if you would. Well, Brianna, it looks like we're trending pretty heavily with the C or BCMA, although we've got about a fourth of folks thinking it might be CD22. Which is the answer that you were looking for?
All right, the most success right now has been seen in BCMA.
All right. And we'll go ahead. Thanks so much for everyone for trying that out. We'll go ahead and go on to the next slide.
All right, so BCMA stands for B-cell maturation antigen. It's very heavily expressed on plasma cells, which are the cells involved with multiple myeloma, and is minimally expressed on normal tissues. So we talked about earlier, that's what kind of makes a good target for the CAR cells to attack. Next slide. So we're going to briefly go over the 2 trials in myeloma CAR T therapy looking at BCMA CARs that are the furthest along. There are quite a few in production right now, and we'll briefly talk about those next. But the one which has kind of been out of the gate first is the KarMMa trial. I have to say multiple myeloma CARs I think are really winning in their trial names. So we've got KarMMa and CARtitude that we're going to be talking about. For the KarMMa trial, they did present their phase 2 data at the most recent ASH conference in 2020, this past December. And so the trial did have prior lines of therapy that were required, at least 3 prior lines. I mentioned over for CARtitude, but also for KarMMa, they did have a median of 6 prior lines of therapy. The overall response rate for KarMMa, which is ide-cel, we're going to call it that. And luckily it has a pharmaceutical name too now. The overall response rate for all comers was 73% with CRs of 37%. Of that, 28% of those were stringent CRs, which is important to have a deepest response as possible in multiple myeloma. The cytokine release syndrome, or CRS, rates were about 83% of patients, but similar to the follicular lymphoma patients, these did not tend to be very severe CRS, although one patient did die from CRS on the trial. The ICANS, or neurotoxicity, which we'll talk a little bit about that later, that rate was about 18% of patients, and again, none of those were severe. For progression-free survival, this is where in multiple myeloma we often have issues. We can maybe get a response, but the relapse rate is obviously very high, especially in this heavily pretreated population. For all dosages of the Karma that was on the ida-cel, which was on trial, they had about an 8 to 9 month progression-free survival. It was actually 8.8 months. And at the highest dose, if you filtered those out, there was a 12.1 month progression-free survival. The median follow-up for patients was 13.1 months. And I'm sorry, I'm actually looking at this. There were actually 128 patients. I don't know why I felt badly about that last patient on that trial. I don't know why we're 27. For Cartitude, this is a Johnson & Johnson product. It is currently recently presented its phase 1b/2 data. It is fully enrolled for its phase 2 and currently enrolling for a phase 3. It has 97 patients that reported on, again, at least 3 prior lines of therapy with a median of 6 in the population that they treated. Cartitude has some pretty remarkable results thus far. They haven't had as much longevity or as many patients, so we'll see how these numbers play out once they get more patients on trial. But they had close to 100%, 97% overall response rate. Of those patients, 67% were actually in a stringent CR, which is really quite incredible for this heavily pretreated population. The cytokine release syndrome rates were high. It was 95%. However, these all tended to be primarily milder cytokine release as well. And I believe most or all had resolved around 14 days afterwards, so not really extending too long. The neurotoxicity rate was similar to Karma at 21%. Their trial has not had as much time to gather data. They have a 6-month progression-free survival that they reported of 87%. Still, their response and CR rates were pretty incredible. So we'll see once they release data from their phase 2 how those numbers really pan out in the long run, and hopefully we'll see those holding up. Next slide. So the data from Karma allowed Bristol Myers Squibb to gain approval for ida-cel, ABBVIE, which is the brand name for this, for treatment of multiple myeloma after 4 or more prior lines of therapy. Of those 4 lines of therapy, you're required to have one of those be an immunomodulatory agent, such as Revlimid, a proteasome inhibitor like Velcade, and a anti-CD38 monoclonal antibody, such as daratumumab. Next slide. The ABBVIE product was just recently approved. UNC, the last I heard last week, was the only site thus far in North Carolina that has been site activated, but there are many sites trying to get this approval through, and so hopefully we'll be able to be treating those patients soon with this pharmaceutical product. There, like I said, many trials of CAR looking at multiple myeloma as a target, specifically using BCMA primarily. The ones that seem fairly exciting, there are some allogeneic off-the-shelf CARs being looked at that have shown some efficacy. That's using someone else's T cells and manufacturing the cells to be able to be given. A lot of times the problem there is persistence of the cells. The bispecific dual-targeted CAR Ts, looking at more than one target, have shown some promise, and hopefully there'll be some more information coming out for that, but there are still quite a ways to go for that. And then there are some phase 3 trials actually currently enrolling for Karma and Cartitude, comparing CAR to standard of care therapy. There are not currently any CAR to CAR trials ongoing, but I think hopefully we'll be able to start comparing different therapies to each other to really understand how to treat our patients and in which order, especially in myeloma where there are so many lines of therapy that patients have gone through. Next slide. So toxicities, it's not all wonderful cancer treatment. There is some risk associated with this treatment. Next slide. So as a case example, we have a 51-year-old woman with relapsed refractory diffuse large B-cell. She was initially treated with R-CHOP for 5 cycles, had progressive disease, and received another 4 cycles of R-GDP, again with progressive disease, so fairly aggressive lymphoma. She was initially evaluated for an autologous stem cell transplant, but given her refractoriness to salvage therapy, it was felt that it was a better decision to move forward with CAR-T, and we decided to treat with Axicell, which is also called Yescarta. PET-CT performed prior to treatment did show very bulky retroperitoneal adenopathy, so a large disease burden. Next slide. 48 hours after the infusion, the patient developed fevers. She was treated with Tylenol and started on IV cefepime for empiric coverage for potential infection. Her fevers persisted for 3 days, through day 5, and then she subsequently developed low blood pressure with systolic blood pressure in the 90s. She did not require any pressors. So how would you treat this patient? And I'll let Tim do it this time.
All right. So how would you treat this patient with CRS? A, steroids, B, tocilizumab, or C, continue supportive care only? And if you'll take 7 or 8 more seconds and go ahead and put in what you think is the correct answer. If you're texting A, B, or C corresponding to these. All right. Seems like we're trending toward tocilizumab. How are they doing?
I think that looks great. So our first step would be to use tocilizumab.
Great. All right. And I'll go ahead and progress to the next slide. Whoops, too far. There you go.
Okay, and we'll talk about cytokine release syndrome, which is what that was an example of in a second. Right now, we're going to look at another case example. So, or a further case example of this patient. So she did receive the tocilizumab and her blood pressure improved and her fevers resolved. She was continued to be monitored, and then on day 7, she developed altered mental status with agitation, aphasia. Her ICE score, which we will describe in a bit, so this is, you have to know a bit about what that is, decreased from a 10 out of 10 to 4 out of 10, and then to a 0 out of 10, and she required transfer to the medical ICU for closer monitoring. We did a head CAT scan and brain MRI, which were both unremarkable, and an EEG did show diffuse slowing consistent with encephalopathy. Next slide.
All right, and here we go with our next poll everywhere. So how would you treat this patient with neurotoxicity? A, continue close monitoring and supportive care. B, administer tocilizumab. Or C, dexamethasone. So again, A, B, or C, and take just another 5 seconds or so to go ahead and put in what you feel is the right answer for this, treating this patient with neurotoxicity. And Brianna, it looks like they're settling in on dexamethasone. How are they doing this time?
That is correct. The first treatment would be dexamethasone.
Great. Thank you all for participating.
Okay, and the patient did receive dexamethasone, 10 milligrams IV every 6 hours, and continued until she improved. She had improvement over the next 24 to 48 hours and was close to her baseline by day 10 after CAR T cell infusion. When she was closer to her baseline, we began to taper the steroids off fairly quickly. Next slide. So the first case, the first symptom that the patient had was called cytokine release syndrome. So in the beginning, I described that the cells, T cells, once they identify their target, proliferate, and when they do so, they release cytokines. into the bloodstream, which allows the T cells to work better, but also causes a large inflammatory response. That can cause some problems in the patient. The initial symptom tends to always be fever, or almost always be fever. We have our patients monitor this very closely. The fever itself is not typically harmful, but it can become very high, and it doesn't tend to respond well to the Tylenol. So we use comfort measures and supportive care at that point. What it does signal us to do is to monitor the patient closer for the symptoms that are actually of more concern. Primarily, we're going to be looking for low blood pressure and low oxygen levels. Fever, blood pressure, and oxygen levels help us to grade the cytokine release syndrome. So once you add the second two of hypotension or hypoxia, the grade of the cytokine release syndrome goes from grade 1 to grades 2 to 4, depending on how severe their oxygen and blood pressure needs are. This is a bit of a problem in that the patient could actually have some bad effects from both of those. So we monitor them very closely, and we will use a medication called tocilizumab that I'll talk about in a second that will help to mitigate those more dangerous symptoms. There are other symptoms that can occur, and so we watch closely for them. And so, sorry, that's okay. Once the patient has fever, they will also develop tachycardia. That's very common. We can see liver abnormalities, and you can actually see some neurologic effects from the cytokine release syndrome, which makes it a little bit confusing when you're seeing people who are altered. Next slide. So in 2017, shortly after the first approval for an FDA approved CAR T therapy, they approved tocilizumab, which is used in a lot of rheumatologic disorders for use specifically of treatment of cytokine release syndrome. It is an anti-IL-6 monoclonal antibody, and in our experience works fairly well. The treatment initially was people were frightened it would potentially affect the efficacy of the CAR T cells, but that doesn't appear to be the case. We use tocilizumab at grade 2, so any indication of blood pressure or oxygen problems, and also we're beginning to use it for persistent grade 1, which is fever only, or in patients that are high risk and that they may be older, have other comorbidities. We will be able to use our tocilizumab earlier in that case and hopefully get them feeling better and at lower risk of potentially progressing to higher grades of cytokine release syndrome. Next slide. Another symptom that can occur should cytokine release syndrome not be well controlled or be refractory to the tocilizumab is HLH, or macrophage activation syndrome. This is, for all intents and purposes, basically a very severe cytokine release syndrome, and so we treat this with steroids at this point. We can also treat high-grade CRS with steroids if it is refractory to tocilizumab. And so we'll monitor with labs and keep a very close eye on the patient. Should the tocilizumab or steroids at that point be ineffective, we can use other medications, potentially such as anakinra, which has been looked at for this, to treat that syndrome. Next slide. The neurotoxicity is also called ICANS. It stands for immune effector cell associated neurotoxicity syndrome, which just rolls off the tongue. So this typically presents with an encephalopathic picture. Patients are confused. They may have language issues, handwriting problems, and they family members and caregivers will describe them as not acting like themselves. They can become agitated, they can become somnolent, and in severe cases you can see seizures, cerebral edema, which is very concerning to us as that has led to some deaths and trials in the past, and obtundation to the point where they are unarousable for on the order of potentially several days. Next slide. We assess for neurotoxicity using something called a ICE score, which stands for immune effector cell encephalopathy score. It's even hard for me to recall. The Questions are pretty simple. It's a 10-point scale, so you get 4 points for your orientation. We ask them to name basic objects, follow simple commands, and write a sentence and count backwards. These are all very simple, but patients will progress from being perfect on this score to potentially not being able to answer any of our questions, sometimes in a matter of a few hours. So we take it very seriously if they have any detriments on their ICE score, and we'll begin assessing with MRI of the brain, potentially lumbar puncture or an EEG to evaluate for seizures. We also begin treatment very early for neurotoxicity. Next slide. Here's an example of how handwriting can change. You can see from day 4 to day 5 where someone was experiencing neurotoxicity, back to day 6, the changes can be fairly rapid. Next slide. So our workup, like I said, can include more investigation with MRI to evaluate for cerebral edema primarily, lumbar puncture to ensure there's no infections, and EEG for seizures. The treatment becomes slightly confusing, so when people said tocilizumab, that is not always incorrect. If we are noticing this concurrent with cytokine release syndrome, in other words, they're having high fevers, low blood pressure, low oxygen at the same time, we will also use tocilizumab. However, the first line treatment for neurotoxicity is going to be steroids. We use dexamethasone because it has a good ability to cross into the blood-brain barrier. We'll give this for grade 2 or higher neurotoxicity, which is any detrimental to ICE score below a 7 or any other concerning symptoms. We make sure that there is no concurrent cytokine release syndrome if we're not going to be using the tocilizumab, and the steroids will continue until the patient improves back up to baseline. We don't use tocilizumab because there is a theoretical possibility that it could actually increase IL-6 in the brain in the CSF, and so we're trying not to use tocilizumab as a treatment for neurotoxicity that is presenting by itself. We use anti-epileptic therapy such as Keppra to treat seizures or in patients who are at high risk of seizure as prophylaxis. Next slide. Patients also receive lymphodepleting chemotherapy just to deplete their own lymphocytes prior to receiving the modified T cells. That can lead, as well as the CD19 B cell aplasia, to increased risk of infection over time. This is a recent paper that looked at the areas that we're mostly concerned with. The long-standing risk tends to be with pneumocystis, and we prophylax our patients with PCP prophylaxis until the CD4 count improves. We also prophylax for shingles as well, because you'll see that the VZV risk is longer, and they are also at higher risk potentially of bacterial pneumonias as well, or viral pneumonias. So it's important to keep that in mind after they recover and return home. Next slide. The cytopenias following CAR T therapy can be longer than expected after the lymphodepleting chemotherapy. Most patients will receive either fludarabine and Cytoxan or bendamustine for their lymphodepleting chemotherapy. However, their cytopenias can persist longer than you expect for those, and they can be more than a month in around a third of the patients who receive the CD19 directed CAR T therapy, and to the point where they are still even possibly needing transfusions. With many of the CAR Ts, they are seeing count recovery by around 2 months afterwards, so we prepare our patients for that as well. You can have a biphasic pattern where you recover a bit from the chemotherapy and then counts drop again after a slight recovery. And we try to avoid GCSF for neutropenia in the first month for theoretical risk of worsened cytokine release syndrome, but after the first month, we can give that for persistent neutropenia. Next slide.
I'm just going to, I know we're running out of time, so I'm briefly just going to discuss some of the future directions and UNC trials we have and recently completed. Next slide. First, I'll provide just a quick update about our CD30 CAR T-cell program, which is our furthest along CAR T-cell construct. Our clinical trial of CD30 CAR T-cells in collaboration with Baylor was recently published in Journal of Clinical Oncology, and this was all led by Barbara Savaldo. Next slide. So our first trial, as I said, was a CD30 directed CAR T cells, and this is for CD30 is a wonderful target, but specifically for Hodgkin lymphoma because the malignant cells in Hodgkin lymphoma, the Reed-Sternberg cells, universally express CD30, and it's also not really expressed in a lot of normal tissue, so it's also a wonderful target for CAR T cells. This schema is similar to our trials and also to what Brianne was talking about earlier. Patients undergo collection of their cells, and then while their CAR T cells are manufactured, they were allowed to get bridging therapy or some sort of therapy to keep their disease under control while their CAR T cells were being made. And then when cells were ready, they underwent lymphodepletion, which Brianne just talked about. Basically, the goal of the lymphodepletion is to reduce the endogenous lymphocytes, make room for the CAR T cells, and also increase the cytokines that are important for CAR T cells survival. Initially, we used bendamustine as lymphodepletion. You can, next slide. But then we, because we didn't see a great response as a bendamustine, we added fludarabine to the regimen. And this trial was done at UNC and at Baylor. Next slide. The treatment was very well tolerated, minimal toxicities. In addition, once we added the fludarabine to the lymphodepletion, we saw excellent responses. So these were really heavily pretreated, high-risk patients of Hodgkin lymphoma who had done really poorly with prior therapies, and they had response rates over 50% with complete response rates between 50 and 75%, depending on the lymphodepletion regimen. Next slide. And also the progression-free survival curves for our patients, our 1-year progression-free survival was about 36%. And we also saw improved outcomes when, as I said, fludarabine was added to their chemotherapy that they got before the CAR T cells. And in patients who achieved a complete response, the median progression-free survival was 444 days, so over a year. And some of these responses seem like they may be durable. We have several patients who are still in remission over a year after treatment. And on the right is just an example of a patient who was pretty heavily pretreated, had done really poorly prior to therapy, had quite a bit of disease in her axilla prior to treatment, and after infusion had a wonderful response. Next slide, and these results led to the FDA granting Regenerative Medicine Advanced Therapy designation for CD CAR T cell therapy for Hodgkin lymphoma this year, and Tessa Therapeutics is working on commercializing the product with plan to open a pivotal trial for this later. And then moving on, the concern about toxicity, which Brianne just talked about, next slide, was amplified in 2016 when the Juno clinical trial was halted by the FDA due to 3 deaths from neurotoxicity from the CD19 directed CAR T cells. Next slide. So our currently open CD19 trials, as well as some of the other trials of new targets, have what we call an inducible caspase-9 safety switch. And basically, the safety switch can be activated when someone has life-threatening toxicities. So we think about cytokine release syndrome and neurotoxicity. So patients with really severe toxicity are treated with AP1903 or rimeducid, which is a dimerizing agent. And it's a chemical inducer of dimerization. It leads to apoptosis or death of the CAR T cells, so causes the CAR T cells to die. Next slide. And we have a trial of CD19 CAR T cells with a safety switch, and the PI that is Matt Foster, and again, this is the work of Dr. Savaldo and Dr. Pietro Dotti, and we had a patient recently, a 26-year-old patient with refractory leukemia, who several days into treatment developed really bad neurotoxicity. She had non-convulsive status epilepticus, refractory seizures, and persistent stupor. Lasted for 72 hours despite being treated with steroids. And basically, she was treated with rimeducid. Next slide. And this was the first time that we activated the safety switch for CAR T cells. And her neurotoxicity resolved hours after treatment. And this also correlated with the decrease in the CAR T cell PCR as well. And so this demonstrates the feasibility that you can manage life-threatening toxicity. And we're now looking at kind of giving slower doses of the dimerizing agent, so maybe we can mitigate toxicity but leave some of the CAR T cells around as well. So we're looking into that. And I think this is also really useful for, as we go into solid tumors and are looking for targets we don't know as much about, we can potentially have the safety switch built into into the CAR T cells, so that way if we get a toxicity we don't know about that's life-threatening, we can kill the CAR T cells. And then next slide, we have a lot of other open CAR T cells in lymphoma, myeloma, and we're also moving into solid tumors. We have neuroblastoma and osteosarcoma, ovarian cancer as well. So we're really trying to move into the solid tumor space. Next slide. And there's a lot of challenges of CAR T cells of solid tumors around kind of heterogeneous expression of the tumor-associated antigens, so they're harder to target, more difficult to find a universal antigen that can target them, and also challenges around limiting trafficking to the tumor site because they have a very immunosuppressive microenvironment. And so we're really looking at different ways to overcome some of these challenges in solid tumors, both in terms of finding novel targets, more direct administration, so intraventricular for glioblastoma or intraperitoneal for ovarian cancer, and also modifying the CAR T cells so you can improve the trafficking to the tumor site. So we have a lot of research around that in that space that we're looking forward to. And then last slide, just a summary slide, CD19 directed CAR T cells have shown really promising efficacy in B-cell lymphoma and leukemia, and we have new approvals in the past year for mantle cell, follicular, multiple myeloma, and we talked about some of the big major toxicities, cytokine release syndrome and neurotoxicity, and our future directions are identifying novel targets and overcoming some of the barriers to efficacy and safety. Thank you very much for your attention. Sorry, I went a little bit over.
Oh, no worries at all, Dr. Grover and Brianne. Thank you both so much, and thank you to our audience. We're already seeing questions rolling in. Here's one. Is there any work being done with CAR T and pediatric young adults with AML?
That's a good question. I think for AML is particularly challenging. I think ALL, the nice thing about ALL is that we have B cells that, you can target B cells and you're okay. The issue of AML, when you target cells in the myeloid lineage, that can kind of lead to life-threatening toxicities and significant immunosuppression as well. So it's much harder. But there is work looking at kind of some targets that are more specifically expressed on leukemia cells that are not expressed in normal cells, or potentially saving these patients of transplant. So there is research being done in AML, and also research at UNC being done in AML, but it's just more challenging than to find a good target than other types of cancer.
Great. Thank you, Dr. Grover. Another question. What are the possible dangers of the viral vector transduction of proliferating T cells?
That's a good question. I mean, that was something definitely that the FDA had been concerned about, because they're always kind of concerned about kind of this leading to transduction, leading to kind of abnormal proliferation, leading to cancer or leukemia in these patients. We haven't seen that, but we check beforehand to kind of make sure that the virus is replication incompetent. And we also kind of test further on for patients. We test further on even after we treat patients for what we call replication competent retrovirus that we think has a higher chance of causing this. And this hasn't kind of played out. We haven't seen anything with CAR T cells, any patients with CAR T cells developing these issues.
Okay, thank you so much. We have just a couple of minutes left for questions. If you do have a question, I encourage you to go to Poll Everywhere, any one of those three mechanisms that we talked about at the beginning, and go ahead and share your question with Dr. Grover and with Brianne. What I'm going to do is skip ahead and take care of some of our thank yous, and then we're going to come back and see if any other questions have come in. So first off, let me say thank you to the citizens of North Carolina for their generous support through the North Carolina General Assembly of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank our team for making each and every one of these possible. Mary King, Veneranda Obore, John Powell, and Aaron Schmidt. Thank you all for all of your tireless work to make this happen.